Next talk is, Madam is a dynamic surgeon who is currently the director of Trinity Eye Hospital, Thrissur. Over to you, Madam.
This talk for basic people who are having basic machines, a basic setup, because not everybody has access to all the fancy machines and fancy this thing. But one thing, when I'm talking about phaco emulsification in zonular weakness, one thing I would like to make very clear to all of you is that actually zonular weakness is an intraoperative diagnosis in 95% of our cases. Only 5% of our cases actually can be diagnosed pre-operatively. And these are the situations where you would actually, you are mentally prepared to be dealing with zonulopathy. Like when there is a pseudo-exfoliation or there is a trauma, there's some pre-operative, something has been done, pars plana, vitrectomy, something, ultrafluorescent cataracts and all the other surgeries that you just watched, and also these syndromes as well. But when you are in the OT and not expecting a zonular weakness, how would you identify it? So these are the signs of zonular weakness that you need to be watching out for. So the number one thing is that you will notice that there is a zonular weakness when you try to start the capsulorhexis. So the lens moves. Then you have punctured the anterior capsule and you are trying to rotate into the CCC, and you notice that there are striae forming on the anterior capsule. And in those cases where there is a pure posterior zonulopathy, only the posterior zonular fibers are weak, you will be able to complete your nucleus management, till that step everything goes very nicely. But when you are taking out the last pieces, you notice that there is a posterior capsular laxicity and the posterior capsule is trying to come to your into your phaco probe. In other situations, when it is little more advanced, there can be a collapse of the lens equator while you are doing the cortical wash. And in advanced cases, of course, there can be vitreous prolapse from the peripheral areas. So what are the challenges that you need to deal with once you've identified that there is zonulopathy? Number one, how would you do the CCC? That is the first challenge. One, I would suggest that you stay calm, always pressurize the chamber adequately, not over pressurized, not under pressurized, and shift to either a microrhexis forceps or an Utrata forceps if that is all that is available to you. And always support the lens with a second instrument. Hydrodissection can be pretty normal, but when it comes to rotation of the nucleus, try to do a bind with the zonulopathy using capsular hooks, CTRs and ring segments, etc. So you should have these in place. So the hardware has to be there in the OT, but many times because you're not anticipating this case in your pre-op evaluation, you may not have these things and you may have to deal with it as and when it comes. So there is no objective classification which is accepted across the world. The best that I could find was this by Yaguchi et al., where they have categorized it as stage 1 when there is a zonular weakness. Stage 1, when you just nick onto this thing, there is a movement, a tremulousness of the lens. Now, stage 2 is where the striae are forming when you are making the rhexis. Stage 3, where you are not able to make a puncture into the anterior capsule and you have to support it with a pars plana instrument. And finally, frank subluxation. So let me show you two videos actually. So this was again like the case that I was explaining to you. It was a routine case. I was expecting only a small intraoperative meiosis for which I put iris hooks in place. Everything looks okay, but now when I start the rhexis, you can see that the movement of the lens is there and there is a difficulty in making the puncture itself. So the entire lens is moving around, and so I support the lens with a second instrument and make that initial puncture and then shift to a Utrata forceps, because that is what was available. On each point when you enter this Utrata forceps, you have to pressurize the chamber adequately. Like I said, do not over pressurize, but there should be enough to keep the posterior capsule, the anterior capsule flat. But at this point you see that the rhexis is trying to go to this periphery, and you can see all those striae which are forming on the, what happened? Okay. So So I completed that rhexis with doing the Little's procedure, and now we support, because the iris hooks are already in place, we support that rhexis with iris hooks. And once that iris hooks are in place, the lens is now adequately supported because it is hanging, the whole capsular bag is hanging on the iris hooks. And then you do your routine nuclear disassembly. But when it comes to the last piece, I would rather go in, because there's a lot of posterior, the whole posterior capsule is coming up, so I would rather go in with there was no ideally you should put a 3-piece lens in this position, but it was not available, not because it was not anticipated. So you go in and do an IOL scaffold and remove the last pieces with the IOL in situ, so that it gives you a much more safer environment to remove the last pieces. And then, so that is how we completed this case. The second case was where there was a zonular weakness noticed during the irrigation aspiration, the cortical removal. You can see the entire bag has scrolled in on itself. So we repressurized it and with viscoelastic, and then at this stage there is no other go but to put in a CTR. The CTR can be applied either with, you can inject the CTR or you can do it manually like this. And when you are putting in the CTR in these cases, it is very important to make sure that the open end of the loop is always facing away from the area of the dehiscence. And once you have put the CTR in place, you will find that cortical removal is a little more challenging than normal. And in this case as well, there are some amount of nuclear remnants as well. So I chose to go ahead and do, you can see that there is so much of fluctuation of the posterior capsule. And once that, this is how you would do the, the tangential, you pull it towards in and towards the center. But even then there is a lot of pressure on the zonular fibers. So again I have put in the IOL here because this is what was only the thing that was available. So these are situations which we face. Ideal situations we know, but it is not always possible to go with the ideal. So we put in the a single piece lens and finally did a IOL scaffold and removed the cortical material as well as the remnant nuclear materials. So the take-home messages that I would like you to keep in mind is that zonular weakness is not as rare as you would think it is. It is almost invariably an intraoperative diagnosis. Do not panic. Have the hardware, that is like iris hooks, CTRs, a few extra than what you would, anticipate for your, what you have already like planned for the day. And with these in position, I'm sure you can do a great job. Thank you all for your kind attention.
That was a nice presentation from Dr. Merine. I can hear that's a talk from experience, the way you have beautifully presented. And it often present with an accident. Many of our juniors will miss on slit lamp. When suddenly we start doing the rhexis, we get to realize there's 180 degree zonular dialysis. So be prepared for the unexpected finding on your table. Next we call upon Dr. Sawhney. I think the difficult cataract is actually not the hard. In reality, it is the soft. And if you have a very high myopia with a small soft cataract and a very small pupil, that is going to make you on your toes when you do the surgery. Sawhney, please.
Good afternoon.